seconds. So we are live now. So once again, welcome to everybody. This another webinar from UP Orthopaedic Association on the very important day, that's World Osteoarthritis Day. So I'll start the webinar by requesting President UPOA Dr. Apur Agrawal to welcome all our speaker and panelists and delegates.
Thank you, Anup. Good evening, respected seniors and friends. As you all know, today is a World Osteoarthritis Day. So UP Orthopedic Association has organized a webinar on this topic. Today we have two very renowned speakers. One, Dr. Sen, President-elect, Indian Orthopedic Association, and Dr. Ravi Mittal from Delhi. We have very senior 4 panelists, Dr. S.C. Goel, Dr. Naresh Chand, Dr. A.S. Prasad, and Dr. Harpal Singh Sethi. Now I request Dr. Anup to kindly conduct the webinar and for further proceedings.
Thank you, sir. As we all know that arthritis is one of the biggest problem in the knee, and there are plenty of way to manage the osteoarthritis. And I'd invite to start with Ramesh Sen, sir, who is not only a very good academician and a teacher also. We all know him very well, and he is also president-elect of IUA. So welcome, Ramesh Sen, sir, and please start your talk.
Very good evening, friends. So I'm thankful to UPA for giving me this opportunity to talk about care of the knee joint, especially in taking care of the arthritis, where we are talking about on the Arthritis Day. And when we look at arthritis, we know, just like we were talking about, this is that 14% of the population is likely to have knee pain, and the arthritis in the knee is likely to become severe enough that 7% will end up in getting a knee replacement done. When we grade knee joint according to the X-rays, we understand its correlation with the inside, that at grade 1 we are losing the joint space to a degree, but cartilage is still left. By grade 2 the cartilage is lost, and grade 3 the even bone starts get losing. 7% will end up in getting a knee replacement done. When we grade knee joint, so as far as the diagnosis is concerned, we have got
please mute everybody.
But cartilage is something which is by grade 2 the cartilage is lost, and grade 3 the even bone starts get losing. 7% will end up in getting a knee replacement done. So when we look about the diagnosis of the, as far as the diagnosis is concerned, so we have got
Somebody is not muted. Everybody is not muted.
By grade 2 the cartilage is lost, and grade 3 even bone starts. The diagnosis will depend upon the stiff. It will be by the complaint of the stiffness, swelling, crunching feeling in the start of the disease, and later on patient can have a lot of deformities coming up over there. Now, what is the gender difference? We all appreciate the ladies get more common. This paper of 2019 says the percentage is 24% in women vis-a-vis 18%, and it's multifactorial. Interestingly, they have found the cartilage loss is relatively higher in women also. So overall, the women are more prone due to many factors in the body. There is a question, are the sports people more affected? The systematic review says it's not the routine sports, it is the high end. That is when we have a competitive weightlifting, we have a wrestling, and these, and especially the collision sports like soccer and football, where we have an increased likelihood, and you can see it is 33% as compared to the other low level of sports which are not competitive enough. Then question comes, what about the occupation? Yes, we have got the various kind of the job. This 2018 paper says The people who are in agriculture worker, the people who go down as a technician, machine operator with their various movements of the joints, they are more prone to get it vis-a-vis the white collar job, the professionals or the office workers. Now, what is the difference? The profile. This paper says the profile, the education wise, low education level are more likely to get. Understandably, obese people get it more, diabetic people get it more. Initially, if the injuries they are sports related, they are more. And the people, again coming down to the profile, those people who have a squatting or kneeling or lifting this thing, they are more likely to be affected. As far as dietary things are concerned, the literature says it is the alcohol that is also a high level alcohol, not the low level of alcohol. High level of alcohol is likely to make a difference, but no other dietary effect can be seen in routine as far as this perception is concerned. Now, what is more important? We understand that this is a disease which needs treatment. A very important thing to understand is that we must value our own experience. That's very, very important. What is our experience in the years we have worked on? Then what is the best possible external evidence, which we look at the literature, we look at the various guidelines. And then, because most of these guidelines, most of this literature comes from the West, and our patient is not from the West, our patient is our patient from our own area. So we have to apply that evidence with our experience, with our patient's expectations and his values. That is what we call as evidence-based medicine. So I'm just adding the external evidence, which we must be able to take in perspective of our patients and in consideration of our own experience in dealing with the knee joint. We know that when we are walking around, at each step, we put 1.5 times body weight on each knee. And especially it becomes many times, 2 to 3 times when we are going upstairs, downstairs, and it becomes 4 to 5 times when we are squatting down. So the Singapore guideline says we must have a weight reduction done, advised if the BMI is more than 25 kilogram per square meter. But if it is more than 30, it should be medically supervised weight reduction program. Then we look at the ORSI guidelines. Now, these ORSI, it is a society, Osteoarthritis Research Society. Now, here, if you look at the graph, this has got a blue area, that's a benefit score. We have a red sides, which is a risk score. So when you compare them as per the ORSI, they have got 4 categories: knee only, knee with comorbidities, multi-joint OA with comorbidities, and multi-joint OA with comorbid, without and with. So it has been found out that we must be able to achieve 5% of the weight loss in a 20 weeks period. And if we are doing it, the efficacy of weight reduction is seen over there, and it's appropriate at any level of care, whether knee alone. Another 2019 guideline, which is published in 2020, again emphasizes it's a strong recommendation that people who are overweight and obese must reduce, and they must reduce along with a very good concomitant exercise program. Every patient will likely to ask, what is the dietary recommendation? So what says that diet must reduce plasma cholesterol, diet might have long chain 3 fatty acids, vitamin K intake may be increased, and we must have a safe level of vitamin D. That is what this paper says. As far as vitamin D, now this is something more interesting. There are 4 meta-analyses which support this, that it affects, but when NIH-funded RCTs was done, they are little plus minus about it. So supplementation is likely to affect, but still there is little conflicting evidence regarding this. But there is no conflict when we say about exercises. Low impact aerobic exercises, stretching and strengthening are likely to help. And when we look at Cochrane collaboration, there is a platinum level evidence that at least for some time, they definitely help in osteoarthritis, in reduction of the knee pain, in improving the knee function. And whether it is American Academy, whether it is ULR, whether it's ORC, every recommendation is there for exercising in care of osteoarthritis. Another very important question is asked is cycling. Now it has been seen cycling definitely increase the muscle mass, increase the knee activity. As per if there is osteoarthrosis, if you want to make it a therapeutic, it has been found it out in this paper in 2020, this year only, that moderate intensity is not very, protocol is not good. It is a high intensity interval training which improves the muscular status and is effective in this thing. Now yoga, again, it is our own system which has gone around, and this is one of the Chinese studies, and what they found it out, that weekly yoga program is feasible, acceptable and safe for older women with knee OA. Now question comes when we have this position. In this position, we always fear that the medial side of the knee joint gets a lot of load. But they say you have the hip external rotators to act more so that the stress on the medial side of the knee is decreased, and then the safely yoga can be made safer also. This is another paper, primarily Indian authors. 4 of these papers are from, then this is a review, systematic review. They say it has got a positive effect in the care of the osteoarthrosis. And this is another paper from Canada, which says that yoga-based strengthening exercises are good. They can improve knee symptoms, they can improve the strength, and they can reduce the chances of osteoarthritis progression. And if it is done as a 12 weeks program, it improves mobility. So when we look at the routine activity, now people say how much I can work, how much I can go around. Again, this is a systematic umbrella review which says physical activity, if it's below 10,000 steps, then it suggests it is no evidence that it will give accelerated progression to OA. It is good. A total of 45 minutes of exercises are important. At that level of activity is important. It can maintain the knee joint in a better kind of a health. When supporting a patient with kind of a support, they say cane is good because it is able to take the load off. And if you look at this ORC chart, you look at the risk ratio, this is minimum. Benefit ratio, the blue lines are much bigger. So as far as single joint knee is concerned, they have advised it is appropriate and appropriate. Though with multiple comorbidities, they are unsure about it. Regarding crutches, the ORC guidelines, they say there is not much of evidence that crutches are likely to help. So they do not recommend it. As far as braces and orthoses are concerned, Cochrane review says that wearing a brace is better because it increases the walking distance, but it may have no effect on pain, knee function, or the quality of life. But American Academy guidelines says it does not recommend this way or that way, and even they are inconclusive regarding the recommendation also. While this paper of 2019 American College Guidelines says tibiofemoral knee braces might be able to help a bit. If the patient is willing to use this assistive exercise, which is a kind of inconvenience, if the patient is comfortable with that inconvenience, he is able to accept it, it might help in getting him better ambulation or a better joint stability. So again, our own experience comes into account in this kind of a situation. Then as far as medial patellar taping is concerned, yes, they say if it is done, it can unload the infrapatellar pad and can be useful if it is done appropriately. Even the patient can himself learn this medial taping. A very common question is what kind of a shoe we are. If you look at those blue line and red lines, you look at it, the benefits are still quite good. And that is what it recommends, that flexible soles, rubber sole with cushioning, because they reduce the stress over the knee joints. They are recommended in this kind of a situation. Very interesting thing is insoles, wedge insoles. And this paper of 2014 says, yes, they will lead to an improvement in foot pain and function, and they're inexpensive for the use also. So they may help in the knee osteoarthrosis also. This is what it says. And we have an interesting experience of our own when the patient came after a year to me that you have advised a year ago this kind of insole. I'm using it. And frankly telling you, it is such a low cost management of a symptomatic. If the patient can afford it, which is not an issue, he can use it, he can maintain using it for about a year. We could get even the joint space restoration from this exercise to this exercise. You see the difference, but it is a case which came with that kind of a follow-up. But if you look at Cochrane recommendation, they say it may not lead to much of the difference as for the Cochrane collaboration. And American Academy says they do not recommend it, and they are reasonably moderate in strength in saying that thing. Now, this 2019 American College of Rheumatology says local heats by moist or diathermy or ultrasound or packs is effective. Regarding hot packs, the Cochrane review says it does not have much of the effect on edema compared with the placebo or cold applications, but the cold therapy, the ice massage, it is supposed to give a beneficial effect in a range of motion, in function and knee strength, and it also reduces swelling. But it may not help in the pain, but when the rest of the things are helped, patients eventually help in this kind of a situation. Regarding ultrasound, it may be beneficial in improving physical function, but the evidence is not very high, so the recommendations vary, because if you look, then ORC may not recommend it. Now comes to our medications, and first we start with topical. Again, you look at these blue lines and red lines. In isolated knee joint, the risk ratio is not high, but when you come to multiple joints, and meaning by you are applying the local area application at multiple joints, now the risk ratio of the topicals also increase. So the advice of ORC is that for a local joint, whether it is with morbidity or without morbidity, it is an appropriate medication. But when it is multiple joints, it is not certain about it whether we should give it or not. Question comes, which topical NSAIDs? It's a very important thing. Now, this is a study in 2018 where there is a comparison with most of the NSAIDs available. And what they have found it out, that diclofenac patches are most effective for pain relief, and improvement of the function is best with piroxicam. And if you can think of salicylate gel, which has got side effects locally also, most of the other NSAIDs are free from side effects by topical. So another paper, American guideline, this ORC guideline says strongly recommended, must be used even, with no comorbidities, and it's modest. You can use it for about 12 weeks because they don't have a lot of the adverse effects in this kind of a situation. Now we come to oral medications. We know acetaminophen as one of the primary management, and if you look at again the risk ratio and the benefit score seen as a blue risk ratio, if there are comorbidities, our risk ratios are high. If there are no comorbidities, risk ratios are low, and accordingly ORC recommends it is appropriate when there are no comorbidities, but whenever comorbidities should be avoided, but whenever it is to be given, it is a conservative dosing for and duration also. Another which we use mostly is tramadol, and Cochrane review says it is a gold level evidence that tramadol is okay. It might have side effects also, but when you look for NSAID side effects, it is a safer thing vis-a-vis NSAIDs if you are talking about, and Singapore guidelines also recommend that way. The question means which is good? The Cochrane review says most of them are same. There is no difference, and you don't choose on the efficacy because you don't have. What you have to choose is you have to choose the safety to the patient, acceptability to the patient, and cost to the patient. So NSAIDs must be weighed accordingly. What ORC guidelines says that they are appropriate. They are looking on the red side. Now you say red lines are much bigger, and now they have divided further low comorbidity risk and high comorbidity risk. If there is a high comorbidity risk, it is not appropriate. With a low comorbidity risk, it is uncertain. It is only when there are no comorbidities you can make it appropriate, and that this is what their chart says. Because all these NSAIDs have a serious gastrointestinal or cardiovascular or renal effect or hepatic abnormality. So whenever we are advising them primarily for gastrointestinal, we must be adding the PPIs along with it. Relative to that, COX-2 inhibitors are safer for GI risk, but they do have a cardiovascular. And if you again look at this side of it, that in these cases also the risk ratio is reasonably high. So NSAIDs are not really very good vis-a-vis the benefit ratios, but when you have no alternatives, you might have to give it. So what it is said about commonly prescribed, if this is one of the paper, it's not a guideline, it's just a paper which says it was studied in, I think, Egypt. They said that most commonly aspirin is used basically for other causes also, but diclofenac sodium is 25%. But what is important is when you are combining these NSAIDs with aspirin, you are likely to have a very complicated complications coming up nephrotoxicity as well as GI toxicity. This is 2020 guidelines from NICE, and we know they have got a very good. What they are advising: start with paracetamol or local NSAIDs. Then, if you do not get a relief, you can shift over to oral NSAIDs or COX-2. Give a lowest effective dose, shortest time, co-prescribe with PPI, and don't compare because all of them will have a similar effect. When you choose NSAIDs depending upon its risk factors. This is very important. The prescription is not on the efficacy, it is on the risk factors which you have to see. Now, if you look at gastrointestinal risk factors, this is a Delphi guided experts consensus statement. They say eosinophilic, celecoxib, ibuprofen are the safest as far as risk ratio is concerned. Rofecoxib group and the second line is relatively high, and piroxicam, etc. are the highest in the risk category in these cases. So when we are prescribing NSAIDs, what we should see? First, we should see when we have to go for NSAIDs, whether patient has got a low GI risk or when he got a high risk. If it is a high risk, we look at it, what is the cardiovascular risk? If cardiovascular risk is low, we can go with celecoxib. If it is high, we can go with celecoxib, but always we are combining it. And even very high, again, we should avoid as much as possible. If GI risk is low, again, we look whether patient is on salicylic acid or not. If it's on salicylic acid, stay with celecoxib, that is low dose. If it is high cardiovascular risk, but no salicylic, we can combine naproxen or low dose celecoxib. And if it is low risk, any NSAIDs can be given in this kind of a situation. Now we come to so-called other therapies, the nutraceuticals, in which glucosamine. Now Cochrane review says they may be better than a placebo. They may reduce pain, but American Academy says they don't recommend it. And you look, their recommendation is very strong. They say it is a placebo only, doesn't make a difference. The ORC guidelines differentiate between symptomatic relief and disease modification. For disease modification, they are anonymous, no effect. But for symptom relief, now you look at their risk ratio also, almost equal to their benefit ratio. So they say there is mixed result. So they are uncertain whether they should be given or they should not be given. And same is for chondroitin also, though the risk ratio of chondroitin is less. But again, symptom relief can be there, but they don't advise it for disease modification purpose. For symptoms, they are uncertain. Again, it's our own experience which can help in that situation. In contrast, diacerin is little more acceptable. The Cochrane says there is a gold level evidence that there is a consistent improvement in pain, but it does not slow down the progression of osteoarthritis, which we may think, and it has got its side effects, so we have to look for those things. The ORC guidelines are doubtful about this effect. They say there could be small statistically significant benefit, but risk of diarrhea. And if you are comparing with NSAIDs, obviously it's better, but you decide on your own clinical experience regarding diacerin. But regarding S-adenosyl methionine, everybody is clear, the Cochrane is very clear, it is not advisable because we do not have any efficacy proved for so-called SEMI, which has been in the market over there. Duloxetine is one which in India we don't use it very often, but it is supposed to be good, tolerable, especially from the chronic pain associated with it. It has some side effects, but if you look at the guidelines, the risk ratio is minimum in them, benefit ratio is much better, and so it is appropriate for osteoarthritis in most of the situations. Now we talk a bit about the complementary medications. We know herbal medications right now is coming up into the allopathic medicines also. They are primarily used that we can avoid NSAIDs in this kind of a situation, and they have a valuable anti-inflammatory activity in some of the studies. Rosehip powder is one of the first thing which came out in the Cochrane review also, where there was one study which is taken into Cochrane review. They say it could help it out in this kind of a situation. It may improve activity of daily life. It can improve stiffness and patient. What ORC says about it? It does not find much of the risk with it. It finds positive effect of it, but say it is uncertain. So a clinician will depend on his own judgment in his own patients whether he wants to give it. This is a fruit from USA, avocado. people know about it. This has got some finding which is taken up in Cochrane that it is convincing evidence it could be good. Now it is available also. What ORC says, it doesn't find very risk with it, very high risk. It's a very low risk thing. It is small benefit. They also feel it out that this is something which can be advised to the patients. Then our Boswellia, which is very often being now put up into the medications in various therapies. This paper, now I'm not quoting guidelines, these are papers now. This is this year's paper only, which says it is effective and safe treatment and recommended duration is about 4 weeks period. Our home remedy, that is ginger. Now I have picked up 3 studies for this thing. First study was a crossover design, which did not say that it is useful, but another study said, yes, it is better. It's the improvement is better with ginger. And third study also said it's better. That was again a crossover trial. Now, this is coming from New Zealand side, this green lipped mussel, and this is a market preparation where I have picked up 2 studies. One study says no difference. Another study says yes, significant difference. So again, it depends upon us to take care of this prescription. Now, this is a Government of India project for efficacy of, you can see the various ingredients down there. They found this C-coded gradient to be symptomatically better in prescription. So depending upon whether we get it or not in the market preparation, but this is, they have found it could be useful. Question comes about Chinese medicines. This DJD, Disheng decoction has been found to be good in various studies. Most of them are from China. They feel if combined with the allopathic medicine, they have got a better care. This is what say. And now the question comes about homeopathy. So I picked up some studies about homeopathy when it was compared with allopathic medicine. Now first is compared with paracetamol. They did not find difference, meaning by it is effective similar to the paracetamol. Another study was done in phenobarbital comparison. They did not find it to be as good as phenobarbital. Another is about the gel, which they found useful near to the gel as such. So this is something which is a low level help can be done. Again, coming back to overall guideline of ORC, they say we must stay with the core treatment, that is a land-based exercise program, dietary management program, and mind, body, and yoga exercises. And patient must be told about it, induce optimism in the patient for this year. And when we look overall, if you look at those strongly recommended things, it is exercise, it is weight loss, it is self-management program, Tai Chi they have advised, TB for braces they have advised, cane they have advised. And what is not there, TENS they have been strongly recommended against, and rest are in between in this kind of a situation. A bit point about intra-articular. Now intra-articular, you say risk ratio, they have made it very low, the benefit ratio is very high. So it is appropriate at each level of involvement, whether it's small joints or bigger joints or comorbid these things. And Cochrane review also supports the use of these steroids in the treatment of osteoarthritis. Another 2019 guidelines also, again, injection strongly recommended for patients with knee may contribute to cartilage loss, but they say it is recommended for making the patient comfortable. Regarding viscosupplementation, Cochrane review supported it, but American academies are strongly against it. They say we don't recommend it. ORC, when you look at it, there is a reasonable amount of a risk ratio also. So they are not appropriate and they are uncertain, the ORC guidelines also. While this 2019, there is a systematic review which says 7 studies said it's improvement, 3 studies said no improvement. Again, now it is for individual experience which can make this thing. Now the question which we just asked about, we were talking about the platelet-rich plasma. There has been few studies which say it could be most effective conservative management. This is a 2019 study. Another study, another kind of a systematic review says 2 studies they have found it out where there are no side effects, but pain and swelling were there. I mean, this is still led data being built up in this direction. And same is true from mesenchymal cell. There have been 5 studies, BMAC in 4, and adipose tissue derived cells in 1 study. They found improvement, but sample size has been very small to make a conclusive statement. Well, this is another study which has looked at various resources. They say it could be useful, but much of the result cannot be guaranteed. So when we give an overview, we again start with the good amount of exercises, need-based oral NSAIDs, can give intra-articular steroids, and they particularly, this ORC guideline says, this is from 2019, that duloxetine can be given that respect in management of these cases. So now the question becomes, this is a nice guidelines when we have to refer the patient, when we have a substantial problem with the knee, when the functional limitations develop, severe pain develop in the knee joint, and patient must be told about any intervention for the joint when to consider for. Arthroscopic Cochrane review says does not improve the, so not recommended. American Academy says not recommended. Proximal tibial osteotomy, we will have a big lecture, but basically as a part of the covering this, this is a younger patient. Now this is a patient where you do not want to do any bigger intervention. This is a small surgery, not a big surgery. And you see by 3 years, you get a reasonable amount of a benefit in the joint restoration also. Another patient, we did one side high tibial osteotomy. 3 years later, he asked for the other side osteotomy. We did other side osteotomy. And this is 5 years, 2 years follow-up. He's able to manage himself reasonably well in this kind of a situation. Now, both these silver level evidence in Cochrane review and the other review also recommends this to be a procedure. American Academy recommends, nice guidelines recommend that osteotomy is a good, and we will hear a lot about in the subsequent lecture. Now, recent thing which has been talked about is the proximal fibular osteotomy. And about it, one thing is certain, the literature is still to come up. There is still a lot of things to be done. So we are just in the very early phase of it. Unicompartment arthroplasty is a defined thing with proper prerequisites you can do. It's a small surgery. And if we have got certain guidelines, if we are able to have them think, this is one of the good surgeries which can be done. And if you are doing it, this is something which can give us a reasonable amount of outcome in patients' day-to-day activities also. So it can go very well with ability to sit on the ground, ability to go on the ground. So I'm sorry, this. I'm sorry for the breakage. Probably doesn't want to go beyond that. Or let me start it.
Yeah, I think.
So this is end. So I'll just close the program and come back again to it.
That's fine, sir.
Just a minute, I'll be there.
Yes, sure, sir. Please.
So just before going further, there is definitely a comparison between UKR versus HTO. We might have more in discussions, but for a younger patients and particular kind of a HTO could be optional. UK, we will discuss more. Now the question comes when we are going for replacement as such. When there is a significant knee pain, when the chronic inflammation does not improve with rest and medication, when the knee deformity is quite high, and that is the area when we have to go in for. Is it visible or no?
Not visible, sir.
I'm just making it, there is some issue with it. So I'll just get it. Just a minute. Is that okay?
Yes, sir. Perfect.
So now there is a very interesting paper in which it is seen why orthopedic surgeons are advising knee replacement. You look, I have labeled few with the high percentage. Most people do with activity of daily life when they are affected, when the low quality of life is there due to knee pain, when severe pain is there, walking distance is limited, conservative treatment is not effective. That is why the doctors are advising knee replacement. So if it is done timely, it is a best surgery which can be done in this kind of a situation. But if we are delaying it to this level, then this is something which creates a problem. And that is something where this surgery has no parallels. Nothing can do as good as knee replacement surgery can do. Now, this is a very important thing. How many times we are delaying it? It has been seen 90% of the knees when they should be done have not been done. And because this is a paper from USA, the black race does not get it, as most of our village people do not get a replacement when it is timely advised. And on the other hand, 25% of the knee replacement are done before what they are indicated. Maybe younger patients living alone, normal weight, and economic necessities, maybe their reimbursements make them to get it early in this situation. So I'm just putting up in 2 or 3 slides the experience of my 1700 TKRs in 950 patients with unilateral, primarily it is bilateral and primarily it is females. And this is the evaluation. I have done this European quality of 5D 3L scoring in them. And if you look at it, most of the patients get benefited. 82% get good mobility, 80% self-care, 86% usual activity. And if you look at the downmost, if you ask them about their health, they are 90%, 96% people feel they are as healthy as possible. So that is the efficacy of TKR if done in a properly indicated case. So to sum up, what is timely care of the knee is that we set basic standards. We talk to the patient about, educate him, weight loss, exercise program. We give topical NSAIDs. We give this thing. Then we ask a physical therapist for the braces or insoles, walking aids, manual therapy, taping. If patient is not comfortable, we assess the gastrointestinal risk. Depending upon that risk, we start, and then we look for cardiovascular risk. We look for renal risk and accordingly decide. As I said earlier, the NSAIDs are to be given in relation to the risk factors, not the efficacy. Efficacy-wise, they are not different. And if they are not still okay, they are still symptomatic, we go for intra-articular steroids. And we can still try opioids. And if these things do not work, the joint replacement becomes the best option. So what we have to say is that we have to take care of the knee so that we do not end up that level. We must be able to take care of the joint before that thing starts. Thank you.
Thank you, Dr. Ramesan, for yet another wonderful talk and nicely elaborated each and every point of osteoarthritis. We'll take up the questions in the last, though we have in few the chat box. Now I would invite Dr. Ravi Mittal. He'll be speaking on myths around high tibial osteotomy in knee OA. Dr. Ravi Mittal.
Good evening, everybody. I'd like to thank the UP Orthopaedic Association and Dr. Anup in particular for this invitation. So I'll be speaking about the myths around the high tibial osteotomy. I have no financial disclosure. Another disclosure that I would like to make is I'm not against joint replacement in the knee. I myself do it. What I want to just emphasize is the importance of the HTO and how it compares with the other procedures. So we'll discuss about the HTO in general and then about the myths around the HTO. So how do we select the treatment for osteoarthritis of knee? Dr. Sen has already elaborated that we start with the non-operative methods like physical methods, analgesic, some nutraceuticals. If they fail, you go in for some injections, hyaluronic acid, steroids, or maybe PRP. If they fail, you go for operative procedures, which may be arthroscopy, HTO, or replacement. Replacement can be uni or total. Now, arthroscopy has a very limited role. It is useful when there is a loose body or a torn meniscus. There's hardly any role for the so-called the washout of the knee. And arthroscopic suitable for the cases where the cause of pain is mechanical and not from the articular cartilage. Now, knee replacement is very popular today. It is widely and aggressively marketed by the manufacturers, by the dealers. It is the patients come and demand this procedure because they have heard about it and it has become a fashion now. It has become a status symbol to have a knee replacement, and that too the costliest implant. And our fraternity also goes out and sell these procedures left, right, and center. But what is not told about the knee replacement? That man cannot become God. The longevity of the prosthesis is limited. There are many physical restrictions which are imposed, and there's an altered lifestyle that the patient has to undergo after knee replacement. Now, all these things are often not told to the patient. Ideally, any implant should outlive the life of the patient, and he should receive only one implant throughout his life. Now, this is possible if the surgery is done after 60 to 65 years of age, and if it is done earlier, the patient would eventually require a revision surgery, and revision surgery is always more difficult, has more complications and more chances of infection. After a knee replacement, he cannot squat, cannot sit cross-legged, and it is advised to avoid running and impact sports to the patient. There's an altered lifestyle. He cannot sit cross-legged for puja or sajda, cannot sit on floor during various social gatherings, and profession like gardening, farming have to be abandoned by the patient. And a person who is living in the city, he cannot run after the bus and train, which is a common scene in the cities. So who is best suited for a TKR? It's the elderly population more than 60 to 65 years of age, where non-operative measures have failed, and it is a bi or tri-compartmental disease, which is the late stage of osteoarthritis. But what to do if the patient is not best suited for TKR, that is, who are less than 60 to 65 years of age, have only medial compartment affected, and in these, the non-operative measures have failed. So here comes the role of HTO. So what is HTO? It is by this procedure, we shift the mechanical axis from the medial compartment to the lateral compartment. And how much to shift? Now, it is the osteotomy is done in such a way that the mechanical axis passes through a point which is 62 to 63% of the mediolateral width of the upper tibia. That's called the Fujisawa point. It can be done a closed wedge or an open wedge osteotomy, and accuracy of the procedure determines the clinical outcome. So the prerequisites for HTO in osteoarthritis is age less than 60, varus less than 15 degree. It's a pure medial OA, and the patient has metaphyseal varus. The varus should not be in the diaphysis. The contraindications include bicompartment or tricompartment disease, or a lateral isolated lateral compartment osteoarthritis, fixed varus more than 15 degrees, flexion contracture more than 10, range of motion less than 90 degrees, there are associated bone loss or subluxation more than 1 centimeter. These are very standard indications and contraindications for high tibial osteotomy. Every textbook describes this. So how does it work? It has both mechanical effect and a biological effect. In the mechanical effect, we see that the mechanical axis is shifted from medial to the lateral compartment. Hence, the medial compartment is unloaded and the pain on the medial side is relieved. The biological effect, it decompresses the medullary hypertension in the proximal tibia and the pain is reduced. But the bottom line is the surgery has to be done accurately. After the surgery, the mechanical axis has to pass through the Fujisawa point. If it doesn't pass through the Fujisawa point, the results are not good and it brings a bad name to the surgery. So HTO is good for pain relief, imposes no restriction of activities to the patient and no change in the lifestyle. It is cheaper and very much suited for the Indian conditions. But is HTO a new procedure? No, it's a very old procedure and it is even older than the TKR. Then why are we talking about it? Everybody knows about HTO because we would like to re-emphasize that TKR is not suitable for everybody. HTO is a good option in medial OA in patients who are less than 60 to 65 years. And today, newer techniques of HTO are available where angle stable implants are used, and the patient can be mobilized from day one. So the types of HTO could be a closed wedge, open wedge, or dome osteotomy. In a closed wedge, a lateral based wedge is removed. The gap is closed. Some people don't use any implant, some use some K wires. Generally, a POP cast is given. So people who object to HTO have raised this issue that there can be undercorrection or overcorrection of the deformity because you are held up with the gap in the proximal tibia, the wedge you have removed. You cannot overdo it or undercorrect it. You have to do a fibula osteotomy. There's a truncation of the proximal tibia after the surgery. So a future TKR is difficult. Early mobilization is difficult. But in spite of all these issues, the functional results of closed wedge osteotomy is good. Now, all these problems have been overcome by the open wedge HTO. You can do accurate correction because the open wedge, you can titrate it under image intensifier. You don't require any fibula osteotomy. There is no truncation of the proximal tibia. So the placement of the tibial tray in the proximal tibia is not a problem issue. And you can mobilize the patient early since you do internal fixation. Now, all this has been possible now because now we have the availability of pre-contoured angle stable implants. They provide good initial stability and the construct remains stable over a period of time till the osteotomy heals. Now we come to various myths and frequently asked questions. Who has spread this myth? We don't know. But this is prevalent among patients, among doctors, even orthopedic surgeons and physicians. Now, many people say that HTO is an abandoned procedure. It's a very old procedure, and we have now new procedures like replacement. So this should not be done. This is a thing of a past. My submission is no, this is not an abandoned procedure. It is really an in thing today. The problem is we have a Walmart-like approach of the doctor. Now, what is Walmart-like approach? So I'll show you one picture here. This is a picture from a superstore or a Walmart. So you see the main walking area. There are some shelves in the main walking area over the white area, and there are some shelves on the brown walking area. So the company wants to sell some goods fast. They earn to more profit from all those goods. So they are displayed on the white area, which is the main walking area of the supermarket. And things which they are not bothered about, they are kept far away in corners where the people have to really search for them. They don't place the things over there. Another picture. Now these are shelves at various levels. Some are at the eye level, some are very high, and some are very low. So again, the supermarket places goods at eye level for which they are very keen to sell at an early time, and things which they are not bothered about, they keep it above the eye level and below the eye level. So that's the approach of the doctor today. He wants to sell the TKR or UKR, so he tells about it, he preaches about it, but keeps quiet about HTO. Either he keeps quiet or doesn't show much enthusiasm about HTO. So that's one of the issues that makes it unpopular today. Now, the second myth is that HTO is a procedure for underdeveloped regions where the facilities are not there for big surgeries. You don't have clean OTs. You don't have the availability of the implants. You don't have availability of the expertise, or the poor people don't have money for the surgery. So here I would like to give my personal view. All the patents of TKR and UKR implants are held by Britishers and Americans. And we read and learn to American British That changes our thought process, our psychology, and we are listening more to the British and the Americans who talk about knee replacement. We're not listening to other people who don't talk about these procedures. Then the social customs. American and British don't have to squat, don't have to kneel, don't have to sit on ground because of the social customs. Whereas our patients have to kneel, they have to squat, sit cross-legged because of various social customs and professions. HTO is popular in rich nations of Asia and Europe. In Asia, it is popular in Korea, Japan, China. In Europe, it is popular in Germany, France, Italy. So it's not a procedure which is, HTO is not a procedure only for the underdeveloped. It is popular in rich nations also. But the problem is we don't read their literature because their literature is not in English language. They either write in German, French, Chinese, Japanese, or Korean language. Another issue which is raised by the opponents of HTO is that it will cause lateral osteoarthritis in the compartment, lateral compartment. So my submission is no. It took at least 50 years for osteoarthritis to develop in the medial compartment. So it will take another 50 years to develop osteoarthritis in the lateral compartment. So by that time, the patient would have lived his full life and he will be okay throughout his life. Now, this is a very, very big problem and a myth which is circulated in the society today, that HTO is not good when you have a complete cartilage loss either in tibia or in femur or in both tibia and femur. Now, it has been shown by Koshino. He's a Japanese surgeon, and he published this report where he showed preoperative and postoperative X-ray of an osteotomy where there was complete cartilage loss on both tibia and femur, and he performed HTO and the cartilage regenerated. So this is a myth that for a kissing lesion or a complete cartilage loss, HTO is not good and you do UKR or TKR. So this is a wrong statement and a myth. Now this is a paper published from Korea. It says that HTO is a good alternative to UKR for medial compartment osteoarthritis with kissing lesion. Kissing lesion is where you have complete loss of cartilage both on the tibia and femur in the same compartment. So one paper from Japan 2003, other from Korea 2013. So I'll try to show the geographical areas from where these papers have come which support HTO. Another thing which the opponent said that this is a stopgap arrangement. So you do HTO, it will survive for some time, then ultimately you'll have to do TKR. So why go for HTO? Go for TKR only. So the submission is that strictly speaking, that it is a stopgap procedure, but same is true for TKR and UKR also. It is not that they would last forever. But in a properly done HTO, this time gap is long enough to last the whole lifetime. And it is long enough to avoid a TKR later. So the crux is it has to be done accurately. If you don't do accurately, obviously it will fail early and then you have to do some other procedure. So if done accurately, it will last a very long time and it is enough to avoid a TKR later. And I think it's same for TKR and UKR also. If you do it correctly, it will last long. And if you don't do it correctly, it will fail early. Another thing is, oh, my relative or my friend got a HTO, but it did not give a good result. So why should I get it done? I think the main reason is a poor case selection and improper technique. In a poor case selection, if a HTO is done for an inflammatory disorder, for a bone defect, for a fixed flexion deformity or decreased range of motion, ligament laxity or bicompartment or tricompartment disease, it's gonna fail. If there is undercorrection of the varus or overcorrection of the varus, and if it is not done at the cora, again it will help. It will fail. So it is mandatory to check that you have a correct mechanical access after the surgery, and you check intraoperatively using either image intensifier or navigation. Another method, it compromises future TKR. So we will not do HTO. Eventually, the patient would require TKR. I will not do HTO. Again, this is a myth. Literature says that there is no difference between a primary TKR and a TKR done after HTO. And there are multiple reports. In fact, HTO makes the TKR easier when deformity is not to be corrected because that has been corrected by HTO. Now, people compare HTO to TKR, but I think this should not be compared because you have a different set of patients for HTO and you have different set of patients for TKR. On the left, you have a medial compartment osteoarthritis. So this patient would be suitable for the HTO. On the right, you have a bicompartment disease, and this patient would not be suitable for HTO. It will be suitable for TKR. Now, what will happen if you do a TKR in an isolated medial compartment osteoarthritis? Now, most of the TKR which are done in India are performed at this stage. I think it's an overkill. You don't have to do a big procedure like TKR for a disease like this at this stage, because at this stage the patient is relatively young and eventually he'll require revision because that will not last his whole lifetime. And when he's young, you impose difficult lifestyle alterations and physical restriction to this patient and limit his physical capabilities. So TKR should not be done in a disease which is unicompartment. Now, this is not our main topic, but in Japan, it was reported in 2020 that open wedge high tibial osteotomy and TKR, if you compare, the patient reported outcomes were similar. It is just to give you an idea that HTO has good results. Now, the most difficult problem comes HTO versus UKR. That's the most common debate. You have an overlapping set of patients and you have to decide what to do for that particular patients. Your decision would depend on your knowledge and what you see. Your decision for HTO or UKR, your knowledge would depend on understanding the problem and finding a rational solution. And ultimately depend on what you read, who's the author, the place of work. So that will give you a different opinion and what your colleagues are doing. There might be a peer pressure that if somebody does not do TKR, he's a small surgeon. And if it does HTO, he's a small, he's TKR, is a big surgeon. So that peer pressure also plays a big role in deciding what procedure one has to do. Now, to give an analogy, if you have a tire which is worn out on one side, what do? You go for realignment of the tire. You don't replace the tire. And that is what osteotomy is doing. TKR and UKR is like changing of tires. And the bottom line is UKR usually never corrects the alignment completely. You have a metal, plastic, and cement bearing more than 60% of the body weight. So this is a very simple example to describe what you do in TKR, UKR, or osteotomy. Now, if you do a Google search, HTO versus unicondyle knee replacement, you have millions and lakhs of results, and it is not possible to read everything. I have selected a few of them. This report from China in 2017, it says that is the authors were unable to conclude that either method is superior, either unicompartmental or HTO. This was a meta-analysis and systemic review. This is a paper published from China in 2013 in Journal of Orthoplasty. Remember, this is Journal of Orthoplasty, and they say both HTO and UKR show effective and reliable results. Another paper from Journal of Orthoplasty from China in 2018. They say both are good, but HTO group achieved higher range of motion. So the Journal of Arthroplasty is favoring HTO little bit. You have the paper from Germany. They say HTO is more appropriate for younger population and UKR is good for older population. This is data from registry of Australia and Sweden. This is a combined unicondylar arthroplasty data, and they concluded that patients who are less than 65 years of age have higher rate of revision than patients who are more than 65 years of age. So that again indicates that HTO is good for young and active patients, whereas UKR is good for older and sedentary patients. Now, if you look at the Cochrane database, they say that there is no difference in pain, function, and gait between HTO and UKR. So you have reports, you have registry, and you have Cochrane data, which say there is no difference between HTO and UKR. We talk about Australia New Zealand registry. They found that is 80% of revision of UKR at 12 years because of loosening and lysis. And revision rate is highest in youngest patients. When you convert a UKR to TKR, the surgery is more difficult and the outcomes gives poor results. Whereas when you convert HTO to TKR, the surgery is easy and the result is good. So you decide for yourself what you want. But in literature, you will find reports of some very specific implants. I know you can make out what I'm hinting at. And they report very specific implant results, but these are isolated reports. A registry talks about a much bigger data done by many surgeons. So a registry data is more reliable than some isolated reports. We don't have any big registry data for HTO, but when reports of HTO are compared to UKR registry, it is seen that HTO has better survival in comparable age groups. So when you compare HTO versus UKR, HTO offers you highest level of activities, no restriction at all, whereas UKR gives you only a moderate level of activity and high impact sports are not allowed. HTO can correct flexion deformity less than 10 degrees, and whereas UKR cannot correct any flexion deformity. Now, it is often said that recovery is faster in UKR as compared to HTO because HTO takes time to unite, whether in open wedge or closed wedge, whereas in UKR, you just cemented and the patient is ready to run. But here is the surprise. This is, I have picked up from the AO Recon website. Recon means from the joint replacement website of AO. They say that HTO has an earlier mean return to sports. HTO has an earlier mean return to professional activities, and more people return to impact sports in HTO group as compared to UKR. So a website which is dedicated to joint replacement favors HTO on these points. The proponents of joint replacement say that we can do joint replacement bilaterally in the same setting, whereas bilateral HTO cannot be done. But the answer is you can do bilateral HTO in the same setting, and I have personally done a few of them. They also said that HTO is not backed by long-term data as like the TKR and UKR. So I'll show you a table where you have more than 90% survival of HTO at 10 years. If you look at the report from Koshino, this is the same author I described earlier. This is in 2004. That article was in 2003. He has 97.3 survival at 7 years, 95% survival at 10 years, and 86.9 at 15 years. Look at this, Akizuki, 2008, 97.6 at 10 years, 90.4 at 15 years. Now, this is comparable to any joint arthroplasty in the knee. Now, is the West agreeing for HTO, the Britishers and Americans? Yes. Now, the UK people have realized and the importance of osteotomy, and they have opened a registry for knee osteotomy now in 2015. So if we compare HTO and UKR, HTO is suitable for younger population, whereas younger means less than 65, and UKR is suitable for older population more than 65 years. If there is knee instability, you can do HTO and alter the slope and manage the knee instability, whereas in UKR, traditionally it is said that it is not possible. But I know some people from Oxford group say that you can do some UKR in ACL deficiency also, but that's not a standard thought process. Now you can do UKR in a varus from 0 to 5, whereas you can do HTO up till 15 degrees of varus. Outcome is good in both. Activity is unrestricted in HTO, whereas it is restricted in UKR. Recovery is faster in HTO as compared to UKR. It is possible to do bilateral surgery in the same sitting in both the cases. And if it is fails, any surgery, HTO or UKR fails, you do have to do TKR. But revision to TKR in HTO is easier and it produces uniformly better results. Revision to TKR in UKR is more difficult because you have taken out a lot of bone from both tibia and femur and you have to build up that bone and the results are much poorer. Now, this is the clincher, I think. What does an orthopedic surgeon decide for himself when he has a unicompartment medial osteoarthritis? And many of them have got HTO for themselves. Did they lack any knowledge or information? No. They had the best of information and knowledge. Did they lack money? No. They were good. They had enough money. Did they had a lack of access to joint replacement services? No. They were in the big cities and best of hospitals. Still, they got HTO for themselves. So this is my conclusion. That what do you want to be? You want to be a typical Walmart customer who goes for the most prominently displayed items in the main shelf, which is the knee replacement, or you want to be a well-informed Walmart customer who goes for the best deal, which may be at the far end of the store, which is the high tibial osteotomy. Thank you very much.
Thank you, Dr. Ravi, for wonderful talk. I think you have thrown lights on each and every corner of HTO. And I'm sure now Dr. Prasad, Dr. Naresh Chand are looking for your head. But nevertheless, you have Dr.
My
S.
apologies if
Sir
I
and
have hurt
Dr.
anybody.
Sanjay Rastogi are there to help you.
Yes, Dr. Rastogi बोलने के लिए तैयार होंगे सर.
So before we start with further discussion, I have few questions from delegates. So one of the question is what you suggest for young athlete having medial compartment OA, go for HTO surgery or counseling and drugs for time being? So Dr. Sen sir.
Yes, practically we have seen it out. Again, saying the same thing, the symptoms are coming. We must build up the joint by going good exercising. And many cases with good exercise, my personal perception has been 3 months of exercising for a good range of movement and for good muscle strengthening. Many of them will become settled for their symptoms. And if they settle it down, they don't have to think more. If they still persist with the problem after adequate amount of inputs into the physical therapy, definitely we'll have to go for, depending upon the symptomatology, some infiltrations, because patient is young, so we do not want to get them into any surgical procedures as far as possible. But primary management has to be physical therapy from my side.
Dr. Sen,
Sir,
will it be same for every individual, irrespective of grading of this osteoarthritis?
Sir, as far as physical therapy is concerned, as far as physical therapy is concerned, it is not in relation to the amount of involvement. The specific kind of a physical therapy might differ. If the muscles are poor, we develop the muscles. If the joint range is less, we go for range of movements. It needs to be customized to the patient, but physical therapy must be given a chance. And for that duration, I always tell my patients, wait for 3 months with adequate amount of physical therapy for most of the general, until unless we do have a situation when things are definitely not adequate.
Dr. Sen sir, there is patient already, he's an athlete. He is doing running for 10 kilometers a day, how you feel that the quadriceps is weak?
No, it is not a question of his ability to run, because running is a different thing and what we advise for physical management is a different thing. So any good athlete, if he's developing a degeneration, there has to be, that's what I've said, we have to individualize it. What kind of a muscle weakness, what kind of a things which is affecting him. If it is the joint which is totally altered, obviously at that stage probably our physical therapy is likely to fail. But if the muscles are relatively weak, we'll have to tune for that kind of thing. So what I'm saying is individualizing the physical therapy to a particular patient.
Dr. Ravi, you wanted to say something, please.
Even if you decide for any surgical procedure, either it is HTO, UKR or TKR, you always give exercises post-operatively, and ideally these exercises have to be started pre-operatively so that the patient is very well conversed with these and he can perform these exercises post-operatively very easily. If you teach them post-operatively, it becomes more difficult for the patient. So there is no harm in trying.
Okay.
How long you would like to try it, sir?
Dr.
There is no
Harman,
fixed timeline. It may be at least 4 to 6 weeks should be minimum.
3 months is supposed to be the what the literature says, 3 months minimum.
So, Sain sir, just one query. There's a lot of things coming up about curcumin derived from haldi.
Yes.
Does it have any beneficial role in osteoarthritis?
Yes, the guidelines have not included it. None of the guidelines have taken up curcumin. There are studies. Now, you do not really put up your value on studies. I showed some. Curcumin has just come in this year as an anti-inflammatory. And what the literature, the complementary medicine literature says, they could act as a kind of an anti-inflammatory and might reduce the need of NSAIDs. So might be, but right now, because our focus is on reducing the inflammation in those cases which have got inflammation. But when most of the arthritic things are basically the weakness of the muscles, which is the primary manifestation, and the joint range of movement.
Sir, we have talked of many complementary modalities, but has anybody done a dose-dependent study on it?
This is what has been done on 3 things. It has been done on rosehip powder, which is even taken up by Cochrane review also. Then Boswellia, as I was saying, is also studied reasonably well. There are some other things which they have tried, but as far as avocado concerned, the Cochrane review says it is very good. They have studied the dose dependent also. But
sir, one more last question is, lot of companies are saying rosehip is from Germany, Boswellia is from this place. Are these medicines actually available in Germany and Europe?
Yes, if you look at the Amazon, you will find it out. They are available world over, because nutraceuticals is something, it is off the counter drug, so everybody can take it, whether they are placebos. Frankly telling you, if you advise a physical therapy to the patients still do not value. You ask them, I have been to this doctor, and he gave me this medicine. When I asked them, have they advised exercises? Yes, they told some exercises. So personally, I feel they do not know the value of exercise. So what I do is, I give them the costly nutraceuticals, tell them this will only act if you do exercises. If you don't do exercise, this is zero. So for the saving the cost of that drug, they tend to go to the exercise and they get the benefit accordingly. So you don't prescribe them primarily for that benefit.
What Harpal was asking was that whether these things are actually being used, maybe available. How many doctors are advising them in Germany and European countries?
In USA, they are being advised, sir. In USA, they are being advised. That's the literature says.
Ravi was.
Things like chondroitin, glucosamine, rosehip extract, boswellia, they all come under nutraceuticals.
Yes.
So they are available not in pharmacy, but they are available in as OTC products,
yes,
even in superstores, online stores. So the pharmacy doesn't sell them in other countries. It is the superstores and say general stores which are selling these drugs. Online stores
things like Amway and other these companies are.
Yeah. So the proper pharmacy जिसको apothecary बोलते हैं वहाँ पे वहाँ नहीं मिलेगा ये.
Okay, Anup, your view on nutraceuticals. Sir, Naresh sir, please sir.
Now, I would like to ask a few questions from Dr. Ravi Vittal. The main question which I was interested to ask was, why still in spite of all efforts, why this S2 is only a topic for the CMEs and seminars, not practically. And I do a lot of practice, but I hardly find a patient in a year, the few patients, जिनका HTO हुआ है. But you gave a very, very nice answer. You have given the answer. This is the Walmart approach. And second is your peer pressure. But third, I will like to add is the glamour. As soon as you do your PGMS, you write a joint replacement surgeon. Nobody writes the STO surgeon. So we should, so this has become a topic for the CME symposium. That is one so you have answered it very nicely, Dr. Mittal. I fully agree with you. पहली चीज. दूसरी चीज, my second point is, what is your, pardon?
I would like to add, there are few surgeons who are doing it regularly, including me.
Yes. Yes, Dr. Mittal.
And the other thing I'll say, 10 years back, it was difficult to say STO. Now at least we have come to a stage where even in arthroplasty society, they will ask you to speak on STO. That means people have started believing, and we always follow West. And in West, only 2 days back, there was a AO seminar on OWSTO, knee conservation.
Sir, I have taken some references from Journal of Orthoplasty.
I think we should move the second topic. I think that otherwise it is too long. Sanjay, I fully agree with you. Credit goes to you who made it popular, at least in this part of the country, and the UP at least. And it is a wonderful subject. No, my question is, a young patient of 40 or 50 years, it has got a severe patellofemoral arthritis, which we have not touched. So what is your solution with the medial compartment? Is it HT or something else?
Dr. Mittal.
I can't get your question. Can you repeat that question?
So there is medial compartment involvement with the patellofemoral. It is mainly patellofemoral arthritis. What is the solution?
Sir, if it is a mainly patellofemoral, then the answer is not HTO. You have to do something for the patellofemoral joint.
That is what I want to say. That is what I want to say. It was not touched. In many patients, I found the severe.
Then HTO is not a good procedure for that patient.
My one more question, where there are many panelists to ask the question. My one more question is, why we say the patient should not sit the cross-legged? I think it is a rotation at the hip, not at the knee. Knee is already flat. Why we say the patient should not sit the cross-legged?
Sorry, I can't.
After TKR.
After TKR?
Why we say why the patient should not sit cross-legged?
Sir, okay.
Cross-legged, I think
Sir, most of the TKRs that are done in a patient who has less than 90 degree of range of motion. So your post-operative range of motion is dependent on pre-operative range of motion. So these patients will never get a very good range of motion. Any patient who gets a very, very good range of motion is already having a pre-operative very good range of motion. And in my case, he is not a good case for TKR.
My question is different, sir. In most of the time, now you get the more than 110%, 110 degree. Dr. Ramesh Sen is smiling. Sir, will you help me? Dr. Ramesh Sen, what is your answer, sir?
Yes, and if you remember one slide which I told about yoga also. If you are sitting cross-legged, obviously the medial pressure becomes high. But if you are able to have a lateral rotation due to your good axial rotators, that stress can be taken off. The question is, yeah.
Okay.
Dr. Prashad, sir, your opinion.
Yeah. I think
I'll come.
My patients are allowed to sit cross-legged, definitely everyone. And everyone, that means most of them, because some people do not have so much of flexion capabilities even before surgery, they may not gain the same amount of rotation. If you are obese, definitely you cannot do. So if you are able to do it before surgery, then 100% you will be able to do even after surgery. But if you're not able to do before surgery, I will make you capable, but you can't, like if you don't know how to dance, you can't become a dancer after surgery. So something will have to be realistic. And my question again will be Dr. Ravi Mittal. I do all the three.
Yes, sir.
I do UKRs. I'm doing UKR since 2002. I'm doing knee replacement since 90s. That was 94, 95. And I do STO off and on. So the numbers of STO are very less. It's around 2 or 3 hardly in a year, and compared to what I do a total knee. So the last slide, which one of the slides is showed, is very pertinent, very related. The choice of patients, that number one, and the competence of the surgeon to execute the surgery. We all know the concept. How well we execute the surgery is very relevant. So I'm going to ask you only one thing. What is your threshold of cartilage damage to accept a patient for STO? Because we cannot compare oranges and apple. I do all the three. I have got my selection criteria. My total UKRs have not reached even 100 now. They are in 90s only. Whereas my TKR are in thousands. So the choice of patient is very important. So what is your criteria to select a patient for STO? And what Dr. Sain showed, the amount of cartilage damage varies from simple cartilage damage to moderate, then exposure of the bone or complete loss of cartilage. So if you look at the 4 scenario, which are the ideal patients for STO? That's number one question. Number two question, which is very burning topic nowadays, because ultimately we get a symptomatic relief. That is the idea. We have to think of outcome, not what procedure we do. So how can you compare a fibular osteotomy and STO in any way?
Sir, I'll answer the easier one first. I don't
Yeah.
have any experience about the fibula osteotomy. I can't answer that question. Maybe Dr. Sain can answer. Regarding the STO cartilage destruction, now I showed you two references. One was from Koshino, other from China. Koshino has shown preoperative photographs where there was complete loss of cartilage both on tibia and femur, and postoperatively he showed photographs that cartilage has regenerated. So he has operated on cases where there was complete loss of cartilage. The other report from China, from Korea, was that for the kissing lesion, HTO is suitable. Now, in my scenario, the patient doesn't agree for surgery or come to us till he is very desperate. Otherwise, he's trying everything in the market which is available. Jadoo tona tak wo karate hain, sab kuch karte hain. So my patients who come to for HTO, they always have kissing lesion. That means complete loss of cartilage both on tibia and femur. And I must say their pain goes away after that. And that's what I was trying to do in my presentation, that this is a myth that you don't do HTO in a kissing lesion. This is a myth. This is written nowhere. Nowhere it is written that you can't do HTO in a kissing lesion. It is only propagated by a few people in few conferences, and they're very selected few, and we know who they are.
Dr.
I
Herbal,
think conspiracy theories are not very acceptable anyway. Dr. Sain, anything about fibular osteotomy? Because it really it is said to give a very good symptomatic relief.
As far as frankly, I have no experience with fibrostomy. I don't have my concepts on it. But as far as I know, I do have met some people who started doing it. They found definitely some complications also, and eventually concluded that short-term relief, few months, but later on the problems come up. But when I looked at the literature, while for making these kind of presentations, you find it out that some paper from China are still advocating it. Might be because this is something which has just come up. We might lose long terms. So we still do not have any substantial evidence supporting it. And whatever papers have come, say that it needs proper studies to evaluate it. So probably right now, just being done as a procedure with no definitive outcome reported.
Dr. Rastogi, can you recall something when I was a student under you there? So there was some talks about getting pain relief of osteoarthritis by something like that, which was done in our department. Can you put up some light if you can recall something?
I couldn't get you, Amal.
So there was a time when I was house surgeon, people were talking for gross osteoarthritis. Why not put up a osteotomy of fibula, not taking up a segment?
I don't.
Dr. Arvind Saxena and Sitendra, they used to discuss about this. So any idea? I have never seen it.
I have never done it. But one thing I would like to draw everybody's attention, which was probably not said, the proximal tibia has a congenital tibia vera in Asians. And if it is more than 5 degrees, which in many cases is a clear-cut better indication for STO rather than a UK. Unicondylar is only replacement of a articular cartilage in otherwise normal knee joint. That means the bone structure is normal, the ligaments are intact and stable, and the person is more than 60-65-year-old. In American literature, it is clearly said, people, those who have less experience, and less experience means who are doing less than 20 unicondylar per year, or who are doing it young, because when you are not doing too many, you want to try it in doing everybody. So it should not be done in young. It should be done only when only the cartilage is lost and the bone structure is normal. And this is better results with open wedge high tibial osteotomy. So, and for clarity's sake, the osteotomy around knee book defines clearly the indications when we should be doing open wedge, when unicondylar, when TKR, and it's only when we take the gray areas into our areas, we make a mistake or we increase our limits.
That's what I think very perfectly explained. So it becomes very individualistic also, and philosophically every procedure has to be individualized also. So I think that makes the point. So, sir, Dr. Rasugi, again, any in your practice, would you like to see how much cartilage damage is there, or you will go and even grade 3, even
Loss
grade
of
4 when
cartilage
the bone is exposed?
on the medial side has no meaning. The lateral compartment has to be intact. In fact, it was shown by Dr. Coscino, when there is a complete loss of cartilage, the regenerate is better.
Okay. I've read that paper. That's very leading and guiding for STO.
For only for the last 10 years, now people don't ask why STO, the cartilage, how it can regenerate. There was questions like, it is a fibrocartilage, it's not a hyaline cartilage, but the disease heals. Now, at least those questions are not being asked in conferences.
Dr. Harpal, you wanted to make a comment.
So there was one query that if it's patellofemoral arthritis with medial compartment, the best way clinically to differentiate is if the patient comes with the anterior knee pain, you don't advise HTO. If the patient comes with a medial knee pain predominantly, that is the time you do HTO. Second was why it is not getting popular, because absolutely rightly said by Dr. Naresh, it's the glamour which is involved with the total knee replacement. How many of us have the जिसको कहते हैं कि हिम्मत है कि लिखने की I am only a trauma surgeon,
HTO surgeon,
right? And
HTO surgeon.
how, now my answer is, how many knee replacement surgeons, despite American guidelines, are ready to do a unilateral knee, and how many of them are ready to do a bilateral knee on their own parents, knowing that the morbidity and mortality in bilateral knee is higher? Reason is there is a scare in the mind कि patient भाग जाएगा. When I do HTO, I tell them I will do only one side, you will come back for the second, and they come back. I have yet to see a patient with a unilateral HTO not having come back for the second side in my personal practice.
Harpal, you are right.
I don't have a patients in thousands, but I don't claim so. But whatever number I have, which is beyond 100, none of the patients has not come after one side to be done for the second side. और मेरे को ये बिल्कुल कन्विंस नहीं करना पड़ता, दोनों ही करेंगे, आज ही करेंगे, आपका खर्चा कम हो जाएगा, आपका एंटीबायोटिक कम लगेगा, nothing. And I have videos people dancing with HTO on a frame on in a wedding. People say you can't do it. Once the frame is there, there's consolidation going on. People dance with the frame on.
Wonderful. There is one. Okay, Dr. Ravi, please.
One thing is, you do HTO by any method, you fix it by any method.
Yeah.
The only thing is you have to restore the mechanical access to the Fujisawa point. So you can use internal fixation, external fixation, no fixation at all, only plaster, or maybe do open, closed, dome, whatever it is. But the mechanical access has to be in the correct point. That's the only thing that you have to look for.
Okay, I have two more questions from delegates. One is, when the COVID pandemic started, elective joint replacement was not recommended by IOAS, BOA, etc. What are the written recommendations now, especially from medico-legal point of view, regarding joint replacement, considering COVID? Dr. Sen, sir.
If you look at the UK, where these things have been there earlier than India, the prescription was that in a patient who doesn't have comorbidities, in a patient who is clean case, where the surgical dilemma is not there, you have a preoperatively worked up patient, and then he has been in kind of a quarantine for about 15 days, it can be done. Now, the practice is always to have a patient waiting for about 5-7 days after initial test, retest a day earlier, and he should not have any comorbidities. And if it all comes through, we are able to do it.
Perfect. There's another question. Is there any benefit if we do HTO combined with PFO in varus knee more than 10 degree? Dr. Ravi.
See, if you are doing a closed wedge osteotomy, you have to do fibula osteotomy. So you can combine that. In the open wedge, fibula osteotomy is not required for HTO, but you may combine if you want. It will be an added surgical incision, added dissection, added time, but you may do, no problem.
So if the deformity is more than 10 degree,
and then what the segment that you remove, you can fill it in the gap.
Okay.
Is there any extra advantage of that? Doing proximal, fibular osteotomy?
Sir, I don't know anything about proximal fibula osteotomy.
Dr. Sanjay Rastogi, sir, you wanted to come.
All of us probably believe that if there is a tibia vera or there is a varus deformity in the knee, patients will develop osteoarthritis and tricompartment later in life. If we are convinced that we are absolutely justifiable in recommending patients HTO early enough so they don't go into tricompartment, while the people who are doing only joint replacement will say, wait. Ultimately, you will require knee replacement and then we'll do it. So probably many joints could be saved if it is advised and practiced early enough by a open with high tibial osteotomy.
Thank you, sir. Dr. Sanjay Dhawan, sir, your last comments about...
There's one question regarding deformity. How much of varus we can take with STO? Is there any limit, or we can have any amount of deformity in varus which can be corrected with STO?
The classical teaching is less than 15 degrees.
And when would you like to add femoral corrections to STO?
Femoral correction?
Femoral corrections with STO.
Now, okay. So before that part I have not covered in the talk, that is the preoperative planning. So Dr. Rastogi had talked about tibia vara. So if it is an isolated tibia vara, you have to do high tibial osteotomy. But if there is a varus in the distal femur also, then you have to do a distal femoral osteotomy. If you don't do a distal femoral osteotomy and you do isolated HTO in a combined case, combined deformity, you will have something like a Z limb. So you have to find the core of the deformity. That comes in preoperative planning. We have not covered that part in the talk. So that where is the varus in the femur on tibia, and in particular bone, which region of the bone there is varus, and then you have to do at the cora. So if there is a deformity in the femur, you have to correct the femur also.
Okay. Dr. S.C. Goels, Dhawan,
Sir, yeah. What's your protocol for giving intra-articular steroid injections? When would you like to give them? Prescribe them, and how many number, and with how much gap? If at
So
all you are going
yeah,
for a steroid injection from here.
there was a time when it was a very common thing. Then there came a time when viscosupplementation came and people started avoiding intraarticulars. But the Western literature is very clear, this is good. And as I showed all the evidences, every evidence supports. For me, my indication is that when the inflammatory component in the joint restricts the mobility of the joint, and a safe dose of NSAID is not able to help in that kind of a situation, and definitely we are not looking at any surgical procedure at that time due to any of the reasons. I may not right now elaborate everything, but that is the situation to make the patient comfortable at that time so that he can go for exercises or physical therapy subsequently. These injections are not the treatment, they are the ways to reduce the inflammatory component of the joint, make the joint comfortably so that we can have the physical therapy, we can get back the range of movement, we can get back the muscles to work up again. Because that is what we are looking for the NSAIDs to do. If NSAIDs cannot be given due to renal problem, due to other comorbidities, then this is a safer option which can be given. And usually one, I take it as sufficient. If the patient response is less than 30% or 20%, I don't go for the second. If it is around 30-40%, I ask the patient, if you are not okay, you can get the second one and subsequently third one. So if there is full response in one injection, definitely one is sufficient. If there is very minimal response, none is required again. But if it is somewhere around 30-40%, my perception is then to give you second or third.
So any particular time gap, or
this depends, because first infiltration usually takes 3 to 4 weeks to be effective enough for the patient to realize whether he has been benefited or not. People used to give it at the interval of 7 days, 8 days also. But what is our claim? Maybe we have Professor Goel around here. What it depends upon is the amount of relief the patient feels. So it takes 2-3 weeks. So I do not give them a weekly interval. I go for 3 weeks interval in that scenario.
So there's one question from, can you differentiate osteotomy site OA due to isolated tibia vara or varus only at joint? That means infratuberosity or supratuberosity tibia vara, or in both cases, supratuberosity osteotomy only.
Okay, so in the preoperative planning, you have to find the site of CORA, and you do HTO when your CORA is above the tibial tuberosity or at the joint line. You can do HTO. If it is below the tibial tuberosity, you don't do HTO. You do infra or a diaphyseal osteotomy or whatever, wherever the CORA is.
Okay, thank you. So Dr. S.C. Dr. Sanjay Rastogi, you want to comment?
If patient has a long-term deformity, which has led to osteoarthritis, medial osteoarthritis knee, they probably could be corrected by doing a osteotomy at one level.
Okay, thank you, sir. So Dr. S.C. Goel, sir, your final comment about just to conclude everything, because it can go on. We can go on discussing HTO versus TKR all this.
Still, what
Final comments.
has summarized everything very well, and you can still talk about why to give diacerin or not, and things like that. It is there. When Dr. Naresh asked that question about patellofemoral also, I believe if there are more than one compartment involved, then probably HTO will not act. Why is that true, Dr. Rastogi? If you got two compartments, then you will not do a HTO.
When you do a biplanar osteotomy, then the patella is shifted laterally and it helps in relieving pain.
It will. Okay.
So can we have any experience of PPRP or stem cells from any panelist? Doesn't
As I
complete.
told, at least the literature, I was looking at few years back, because this subject I'm working for last 5-7 years of looking at the literature, defining my prescriptions accordingly. So PRP, people have been trying. They say it is effective, but sometimes this is overdone. When you look at these studies which have come up in last few months, now there is a study which says it could be effective due to its anti-inflammatory activities as far as PRP is concerned. For BMAC, most of the studies said it is insufficient evidence. Now it is just the last 2 studies said there is an evidence it could be helpful. Right now, it is not my practice to give either PRP or BMAC. So I still need more evidence to put it into my practice. But this is what the literature is in the day of today. I don't know anybody, any other panelists have got any experience.
Sir, to my next question is, how medico-legally, how safe are you if you are putting in BMAC or PRP and something goes wrong?
As far as medico-legal thing is concerned, I think, I don't know whether I'm really right or not, perception is something done within the theater without any manipulation of the whatever you are taking out, then it is medico-legally allowed. If you take something out, process it outside, culture it outside and get back to it, that is still not accepted by the medical council, this ICMR as such.
Okay, Dr. Ravi, your comment on this issue.
See, I have no experience about PRP. I also read about PRP until now. I'm not convinced. They themselves are not sure what preparation of PRP is good. There are different kinds of preparation which Dr. Sen had shown in his slide, but they don't know what preparation, what dose, what frequency. This is still an empirical science till now. We stick to standard practices, standard teachings. That keeps us safe.
We must wait for guidelines, these things to come up in guidelines. Still, they are not in guidelines, they are studies only, and I think we should wait for them to be included. That's what I was saying about most of the complementary medicines also. Rosehip is the only thing, avocado is the only thing which has come up in Cochrane review and all those things. Another things have not come up.
Okay. Dr. Sanjay Dhawan, sir, if you permit, should we end the discussion today?
Dr. Naresh,
Last
sir, wants to
question, Anup.
Sir.
Anup,
Please, sir.
last question from Dr. Sen. Dr. Sen के जवाब बड़े अच्छे होते हैं यार. Dr. मित्तल के भी बहुत बढ़िया होते हैं. Sen, Dr.
Sir, please.
How much gap you keep once you give the last steroid injection and TKR?
Okay. Now, there is always an apprehension that any injection is likely to lower the immunological status of the joint. So, again, I go back to literature, says 6 months. It says 6 months minimum.
Dr. Sen, to continue this question, but many people give the steroid local intra-articular.
Yes. I didn't make it out, sir. What exactly was the question?
Just during the surgery, TKR, you
yes.
give the steroid there on, intra-articular steroid there on.
That is basically to reduce the inflammatory component. I think Dr. Prasad might comment about these things, whether he gives or not, I don't know. But that is, they say, to reduce the inflammatory component of that joint at that stage.
Any difference? Sorry.
Yes.
Yes, Dr.
Yeah, Dr. Naresh.
Because we are getting intra-articular injection at that time under that very kind of a sterile environment, while preoperatively when you are giving 6 months or 3 months, the environment is not that sterile. So there is a chance that it might have a low-grade infection induced into the joint. That's the difference here.
Dr. Sen, any difference whether you inject a steroid or you do a visco supplementation through injection?
No, steroid visco supplementation. The literature, whatever it says, the initial earliest relief is possible with steroid because visco supplementation takes time. Second, visco supplementation is effective in only 30% of the cases in which you have injected. Steroids are effective in 70 to 80% of the cases to play the role which they have been used for. So visco supplementation is less effective. And incidentally, a lot depends on what brand we are using. I'm just go for 1 minute more. If you look at before 2000, we had the original thing, Sinvis one coming from international company. It was effective. Then between 2001 to 2007, so many preparations came and reducing the cost. Actually, they were ineffective also. And I remember one of the company giving me about 100 of these vials, sir, kahin use kar lo. I say, I don't believe it now. So I can't use them. And they were wasted out. Now it all depends on what the newer preparation. So many times newer preparation might be, now they have got a single dose things also. But I did myself one of these studies. I did not find it to be very useful, more than 30 to 40% of the cases. And second, the benefit of steroid lasts for about 3 to 6 weeks only. While if it is beneficial, if viscosupplementation beneficial, it can be expected till 2 months. And the perception is that this manages the patient to do the physical therapy so that he doesn't require that kind of a anesthetics again. That is the perception.
Any difference in the time gap between the knee replacement and injection of viscosupplementation, or it's same 6
Viscosupplementation,
months?
no, there is no gap. But for steroids, they say about 6 months gap you have to give, basically to reduce those chances of a low-grade infection.
So I think it's time to wind up. We are overshooted. It's 9:45. Let me thank you both, my speaker, Dr. Ramesh Sen sir and Dr. Ravi Mattal, for wonderful show and wonderful learning process. All my panelists, Dr. Sanjay Rastogi, Dr. S. Prasad, Dr. Naresh Chand, Dr. S. C. Goel sir, Dr. Harpal Singh Seli, and Dr. Dhawan, Dr. Sanjay Dhawan, President-elect, and all my fellow orthopedic surgeons who have attended this webinar. Thank you each and everybody. Thank you.
Thank you very much. Thank you.
Thank you very much.
Bye-bye. Bye-bye. Thank you, everyone.
Bye-bye.